Let me jump to this question because I'd like you to review, if you wouldn't mind, Pedro. We talked early on as we introduced this segment. Historically monotherapy, right, testosterone suppression, agonist, antagonist, bilateral orchiectomy, and in the last few years we've seen this explosion of couplet therapies. Docetaxel, enzalutamide, apalutamide, abiraterone. Can you review some of that data?
Sure. So it's quite an interesting story. It's actually exciting times, right? Things change dramatically. I would argue probably 2017, when we start seeing the data. Initially, the American study charted, we basically compare the treatment intensification with 6 cycles of docetaxel on top of backbone ADT versus ADT alone, and it was shown a survival benefit regardless of volume at that time. The study was positive, right? But then the French study would get to study, which was a negative study, asked the same question, about the addition of chemotherapy to ADT, and we actually did up to 9 cycles in that study, and we start discussing, is the chemotherapy helpful for everybody? And then we start discussing the concept of volume of disease, which until today we still use the Charter definition, which is includes 4 or more bone lesions with at least 1 outside the spine and pelvis, and or visceral disease. And so we start understanding that using a drug that improves survival in the castration-resistant setting, docetaxel, actually also improves survival if you use it early on. And so it was kind of obvious for us to, use other therapies out there who are very powerful agents, such as abiraterone and enzalutamide, and then, and then apalutamide and tested them in that setting, the metastatic castration-sensitive setting, and asked the same question. Does treatment intensifications make people live longer, number one? Number two, do they live better, right? And so we now have data from Stampede, Charted, Latitude, right? So with docetaxel and abiraterone, and then we have Enzamet and Arches for enzalutamide, and we have Titan for apalutamide. And if I have to, we can discuss an hour, we can stay in an hour just talking about all the details about that data, but I think the take-home points from all that data are that the new standard of care for most men with metastatic castration-naive or castration-sensitive prostate cancer should be indeed treatment intensification. So in other words, hormones or hormones plus bicalutamide is not enough, right? The second question that some of us can weigh in as well in terms of quality of life. By doing that, we allow them to live longer, but also to live better, and we delay a lot of symptoms in relation to the disease they develop over time. We know these treatments for the most part are not curative, but they did change dramatically the way we manage these patients, because it brought us another set of questions, such as how do we going to sequence all these treatments? If we're starting using them up front, what's going to happen once they will fail? And so it's an exciting time, and we start seeing, at the same time we start seeing the development of new molecules. At the same time, we start having these studies that ask the question, what actually is the right timing for therapies after we start moving early on in the course of the disease, these agents that you just mentioned?
Wonderful summary of an enormous amount of work that's been done. Let me ask the panel, so now we have this, proverbial embarrassment of riches, right? Prior to just a couple of years ago, it was monotherapy ADT or a clinical trial. Now let's exclude clinical trials, because we all have some really interesting clinical trials still ongoing in this space, which is so exciting. But so you now have ADT plus Abi, ADT plus Enza, ADT plus Apple, or ADT plus Dosi. I'd like to ask you, how has your decision-making evolved since with all these new agents out there? And I think it's kind of unique for the U.S., right? Because in the U.S., we have, as a general rule, access to all of these. The rest of the world is still a little bit of a challenge, with the exception of ADT and Dosi. But so Nancy, how has has it evolved? Has it changed for you when you discuss with someone low volume, high volume, newly presenting?
Absolutely. So I look at these studies, and as you said, when Charter came out and Stampede, they both showed the benefit of docetaxel, but the Charter trials showed that the low volume patients did not benefit. Only the high volume patients seem to have the survival benefit. And so I take into effect the volume. So if it's a low volume patient, I'm probably not thinking docetaxel. In fact, if you look at our NCCN guidelines, they actually tell you that they do not think you should give docetaxel to the low volume patients. the apalutamide, enzalutamide, they work in both high and low volume. Abiraterone, of course, works probably in high and low volumes, but they didn't really break it out quite the same way. I mean, if you look at the STAMPEDE trial, they showed benefits of abiraterone in patients who just have high-risk localized disease with nodes that are involved. So I do now have to look at not only the volume disease, I have to look at where the disease is, I have to look at the patient's preference, of course. It's a much longer conversation than it used to be. And then I look at other reasons not to give a patient something. So if a patient has an ejection fraction that's under 50%, I'm not going to want to give them abiraterone. Okay. If a patient is on some of our anticoagulation drugs, Eliquis, drugs like that, that's going to be an interaction with enzalutamide or apalutamide, so I'm going to have to try to figure that out, change their medications if I want to do that. So I do take those things into account, where the disease is, what their heart function is, whether they have, what their preference is. I'm surprised sometimes how patients will say, well, I'd like to get the chemotherapy. You know, I don't want the oral drug because I'll be on it for years, if they're lucky, as opposed to 6 cycles and you're done.
So that's a really good summary. William, for the audience, and when you have patients come in, and is there ever a role now for not using some form of couplet therapy for a patient who, would you just give only monotherapy ADT to?
I don't think so. I mean, if you look at the survival benefit of these combinations, whichever one you choose, it's just so dramatic. I mean, you're really keeping these patients alive years longer with the second therapy than with ADT alone. And, you know, we're all taking care of patients with lots of comorbidities, lots of other issues, but in the end, they all want to live, and we want them to live. So in my mind, there's almost no situation where I can't offer one of these 4 options. I think the biggest challenge is which one do we choose and why, and there's a lot of variability, as you heard. But for the most part, I don't think there's really almost any person that I wouldn't try to get a second therapy into.
No, yeah, I agree. Alicia, any other kind of contrarian thought to that?
Yeah, so I have seen some patients with pretty advanced dementia that I know that dementia, and I talked to the neurologist, is probably going to be an issue for them and probably cause their death within the next 12 months. And for those patients, sometimes, well, chemotherapy is not really ideal in that patient population because of the risks potentially of, you know, complications that they may or may not be able to cope with. And then there can be problems when I have given some of them, or tried to give some of them, oral agents, because I completely agree with William that, you know, if there is any way to get a second agent and really intensify in, I will always try to do that. But sometimes for people with severe dementia, they can forget to take their pills, or I certainly don't want to put anyone in a position where he's taking abiraterone without his prednisone, because I don't want him to have, you know, hypertension and a stroke. So there are those kinds of situations. Or I could imagine if somebody had such severe heart failure that, you know, the life expectancy is within a year, based on the cardiologist you know, assessment. But it is a very small minority of patients. And I have to say, it is concerning sometimes when we are in meetings and talk to people and they say, well, I like to give the ADT, whatever that GnRH agonist or antagonist is, I see how low the PSA goes, and then if it goes really low, I don't add another agent. In reality, that's not how the studies were designed. And the studies were not considering how low that PSA went, and that should not be a consideration of ours.
That's a great point, Alicia. I really appreciate you saying it. I've been asked that too, and you're right, the studies weren't designed that way. And, you know, market data that I've seen, maybe you've seen otherwise, there's still in 2019 an enormous amount of monotherapy that's occurring. Yeah. So I think that there is still a great educational need for many community medical oncologists and uro-oncologists. So I think this was a great discussion.